about ptosis. Introduction. The upper lid normally rests approximately midway between the superior limbus and the popliteal margin. Considerable variation may exist as long as symmetry is maintained. Ptosis is a condition in which one or both upper eyelids assumed an abnormally low position. Blepharoptosis may be congenital or acquired and can be hereditary in either cases. Classification is important for proper treatment. Bear's Review's scheme attempts to classify ptosis by etiology. This table is Bear's Review's classification of ptosis. Livetal malleable development. Ptosis from levator maldevelopment, formerly classified as true congenital ptosis, is the result of an isolated dystrophy of the levator muscle, affecting both contraction and relaxation of the fibers. Ptosis is present in the primary position of gaze, and there is reduced movement of the lid in upgaze and impaired closure on downgaze. Lid length on downgaze is an important clue to diagnose of levator maldevelopment. Other ocular abnormalities, such as strabismus, are sometimes associated with this form of congenital ptosis. In 25% of cases, the superior rectus muscles share the same dystrophy changes as the levator, resulting in weakness of upgaze. It's important to identify this finding. Successful surgical outcome in the presence of superior rectus weakness requires the resection of an additional length of levator. The distinction between levator maldevelopment and other forms of ptosis is an important one that cannot always be made by history. Neurologic and other myogenic ptosis may be present at birth. Application of the surgical principles intended for levator maldevelopment to these types of ptosis patients would result in a growth overcorrection. Other types of myogenetic ptosis. Blepharophimosis accounts for 5% of cases of congenital ptosis. Poor levator function and severe ptosis are accompanied by telecanthus, epicanthus floats, and secretory axial point of the lower lids. The condition is familial. Chronic progressive external ophthalmoplegia, one form of mitochondrial cytopathy, is a slowly progressive neuromuscular disease that usually begins in midlife. Although it's associated with deletion in mitochondrial DNA, the disease is usually sporadic rather than inherited. All extraocular muscles, including the levator and the muscles of facial expression, gradually become effaced. A wide range of other neurodegenerative disorders may be present. In KS syndrome, ophthalmoplegia, pigmentary retinopathy, and heart block manifest before age 15. Ocular paragenial dystrophy, an autosomal dominant disease affecting individuals of FC descent, predominantly manifest as dysphoria, but also as visual weakness, ptosis, and usually mild ophthalmopia. Ptosis and visual weakness occur in myotonic dystrophy. Other findings include cataract, pupillary abnormalities, photoblindness, testicular atrophy, and diabetes. Ptosis associated with the rare and sometimes familiar congenital fibrosis of the extraocular muscles may be unilateral. Ptosis and diploma commonly occur in myasthenia gravis, and either or both frequently are the initial manifestation of both the ocular and generalized forms. The orbiculars occlu muscles are also frequently involved. Congenitally twitch is sometimes present. On rapid movements of the eyes from downside to the primary position, the upper lid twitches upward. Lid fatigue, increasing ptosis on prolonged upgaze, is a more consistent sign. Ptosis may be reversed by rest or the local application of the eyes. The diagnosis can be confirmed by administration of intravenous endotrophin or intramuscular neurostigmine, which temporarily reverses the neuromuscular junction blockade that underlies the muscular weakness. EMG, particularly single fiber studies of orbiculars occlu in ocular myasthenia or circulating antibodies to acetylcholine receptors or muscle-specific kinase may be diagnostic. Medical management with anticoagulants agents, systemic steroids, or other immunosuppressants is usually effective. Thymectomy may be helpful in selected cases. Aponeurotic ptosis, a common form of myogenetic ptosis, occurs late in life and results from parietal dissension or dehiscence of the levator, a prognosis from the trisoplate. Typically, there are significant residual attachments to the troros to maintain full excursion of the lid with upgaze. Retention of the attachment of the retracted liver, a prognosis to the skin and orbicular muscles, creates an unusually high lead flow. Thinning of the lid may also occur. Ptosis associated with trauma, including ocular surgery, behavioral losses, pregnancy, and Graves' disease, is also usually due to disinsection of the lateral prognosis. A hereditary variant is known as late developing hereditary ptosis. Neurogenetic ptosis. In Marcus Jones syndrome, the ptosis decreases when the mandible is opened or is deviated to the opposite side because the ptotic levator muscle is innervated by motor branches of trigeminal nerve, as well as the oculomotor nerve. Congenital and traumatic oculomotor may be completed by aberrant regeneration, resulting in inappropriate movement of the global, eyelid, and pupil. For example, lid evaluation on downgaze. If the lid is completely closed during childhood, deprivation of amblyopia will develop unless the ptosis is corrected. If the cause is oculomotor nerve paralysis, strabismic amblyopia will also develop unless there is vigorous and early management. Paralysis of Mueller's muscle is also always associated with Horner's syndrome and is usually acquired. Rarely is there more than 2 mm of ptosis, and amblyopia is never a threat. Mechanical ptosis. The upper lid may be prevented from opening completely because of the mass effect of a neuroplastic or the terracing effect of scar formation. Excessive horizontal shortening of the upper lid is a common cause of metastatic ptosis. Another form is that seen following enucleation, when absence of support to the levator by the global permanents may lead to drop. Apparent ptosis. Hypertropia may give the appearance of ptosis. When the eye looks down, the upper lid drops more than the lower lid. The narrow peripheral feature and the ptotic upper lid are much more apparent than the hypertrophic global. Occlusion of the opposite eye, however, reveals the true condition. In severe dermatolysis, a float of peripheral orbiculars and skin may conceal the lid margin and give the appearance of blepharoptosis. Treatment. With the exception of myasthenia gravis, all types of ptosis are treated surgically. In children, surgery can be performed once accurate evaluation can be obtained and the child is able to cooperate post-operatively. Astigmatism and myopia may be associated with childhood ptosis. Early surgery might be helpful in preventing anisotropic amblyopia, but this has not been proved. Depressional amblyopia probably occurs only with complete ptosis, as in oculomotor nerve palsy. Symmetry is a goal of surgery. The symmetry in all positions of gaze is possible only if levator function is unimpaired. In most cases, the best result can be achieved is to balance the lids in the primary position. With unilateral ptosis, achievement of symmetry in other positions of gaze is proportionate to levator function. Most ptosis operations involve resection of the levator, prognosis, or superior transmal muscles, or both. Patients with little or no levator function, as in severe neurogenetic or myogenetic ptosis, require an alternative evaluating source. Suspensions of the lids to the brow arrows the patients to evaluate the lids with the natural movement of the frontal muscle. Ptosis surgery must be undertaken with caution because of the risk of exposure keratitis. Okay, that's all for this lesson. Thank you for your attention. See you next time.